Good morning. Welcome and thank you for coming to Primary Children's Pediatric Grand Rounds. I am Miguel Canacal, one of your pediatric hospitalists and the course director. The Cloud CME claim credit code is 52522 for everybody to claim. Nurses, doctors, pharmacists, social workers, we have so many different professions and people coming to Grand Rounds, everybody can claim the credit. The online questions, you just type them in the live chat. And for those in the auditorium, just raise your hand, and if there's question time at the end, the speaker can call on you. The overhead microphones are sensitive. You could just talk like normal, and everybody will hear it. Okay, would you please nominate a safety hero for Safety Hero Awards when you see someone using error prevention technique? Today, we have a more experienced story, how a child's nurse and our hospital's school zone teacher created a partnership with the patient's school and the medical team and the parent that helped the child have better outcomes. So our 15-year-old who was admitted here with type 1 diabetes had difficulty understanding the nurse's teaching. They were trying to teach it slower, but the parent was overwhelmed at home, also finding difficult to manage the diabetes on her own. So our school zone teacher, with the parents' permission, learned from the school that the teen was receiving special education at school and they would need more support managing diabetes, not just like slower teaching at the hospital. So our team collaborated with the school for the overall insulin plan at the school, with breakfast at the school and daytime dosing at the school, and then the medical team in the school worked with the parent to make strategies for better school attendance, improving the school attendance so that the child could receive the support and the dosing. And so that just shows our community partnerships. Don't be afraid to reach outside the walls of the hospital and vice versa, And we'll try to improve that communication over the next year as well. Okay, switch that. Okay, and our thanks to the medical staff for supporting the David Green Memorial Lectureship. And now Dr. Gretchen Case, the director of the Center for Health Ethics, Arts, and Humanities at University of Utah, will introduce the David Green Memorial Lecture and our speaker as well. Thanks so much.
So it's always my pleasure to be here at the David Green Lecture. This is such a great collaboration between Primary Department of Pediatrics and us over at the University of Utah. For almost 30 years, this has been our collaboration. I want to give special thanks to Dr. Knuckle, Julie Hanks, Camila Castaneda, and Kim Clark for their work on this event. This lecture series is endowed in the memory of Dr. David Green, who is a colleague and teacher to many of you here today. Dr. Green joined the faculty of the Department of Pediatrics in 1983 and quickly became a leader in adolescent medicine. He was key in establishing attention to medical ethics in both the clinic and the classroom. Each year, we look for a speaker who is nationally recognized for addressing questions around pediatric ethics to help us carry on the important work to which David Green dedicated his professional life. And so I am delighted to introduce Dr. Johanna Schoen, Distinguished Professor of History at Rutgers University, New Brunswick. Dr. Schoen wrestles with the complex histories of medical care at the beginning and the end of human life, which are famously where so many ethical conundrums lie. She has written extensively about the history of abortion and won the Welch Medal of the American Association for the History of Medicine for her second book, Abortion After Roe. Schoen also volunteers at Memorial Sloan Kettering Cancer Center, where she is emeritus co-chair of the Patient and Family Advisory Council and works on improving end-of-life conversations between clinicians, patients, and caregivers. Dr. Schoen will be speaking to us today from within the process of researching and writing her fourth and forthcoming book on the history of NICUs, Life and Death in the Nursery, which was supported by a 3-year research grant from the National Institutes of Health and the National Library of Medicine. So please join me in welcoming today Johanna Schoen for the pain debate in neonatology. Thank you.
Thank you so much for that introduction. And thank you so much for having me and for coming and listening to my talk. I have to say, I'm not clinically trained, and so my ability to talk to a clinical audience and to learn on site, kind of what neonatology is like and what it is like today, is really invaluable. It's kind of like a reality check to the things that I make up in my mind. So I can't tell you how much I appreciate it. Before I start, I want to talk for a second about why I got to this and where I'm going next. So the process of writing a book, and this is, I'm going to retire after this one. I mean, I'm actually really liking it, but I am at the age where I can legitimately think about retirement. How you enter into a book project and what the talks are that you write first is somehow a little bit haphazard. So I was interviewing neonatologists at Yale, or who had worked at Yale, Yale being the first neonatal intensive care unit in the country. And one of the neonatologists there was telling me about Helen Harrison, who was a parent-patient advocate, and I'll talk to her about her a little bit today. Who had written an article basically putting forward a number of reforms that parents thought should be instituted in the NICU. And so I looked up the article. He was really the one putting me onto that, and then carefully went into the footnotes and realized that with a Google search, she was no longer alive, but that there was a husband. And then also found two other names of parents who had NICU experiences and who had worked with her. And I just cold emailed these people and asked him whether she had any papers, and then asked the other parents if they could share their experiences with me. And so the very first collection I dove into were the papers of Helen Harrison, which are at UCSF and which are extensive and which have the wonderful quality of really giving you an insight into the parent experience of the NICU, but also to some extent into the patient experience of the NICU. So I start the project intellectually with this group of parents who are really organizing in order to reform the NICU. And so the very first talk I gave about the NICU was about this parent-patient activism. And then the other thing that happened is that I got invited by a friend who's the director of the Duke Bioethics Center to talk last fall at a symposium on the artificial womb. And he wanted me to talk about the innovations in neonatology. And since I wasn't really interested in just doing, and then this happened, and then this happened, and then this happened, and now we're at this wonderful place, I thought about what would be useful for clinicians who are now working on the artificial womb in terms of the lessons that we can learn. And so I had found some material on moral distress of clinicians, which I was really interested in. That is an overarching interest of mine anyhow. How do you people do the kind of work that you're doing in a time period and in an environment where distressing things happen? And so that got me to moral distress, and that also kind of got me into the pain debate. So if the talks sound very critical, that is partly because I'm trying to draw attention to some things that happened in the past that are problematic. But it doesn't mean that I'm super critical about the NICU. It really has partly to do with how I entered the beginning of this topic. So on February 24, 1985, 17-day-old Jeffrey Lawson, born at 760 grams and 25 to 26 weeks gestation, had surgery for a ductus ligation. Jeffrey's neonatologist, John Scanlon, had referred Jeffrey, who was born at Columbia Hospital for Women in Washington, D.C., to Children's Hospital National Medical Center for the surgery. And I just realized I totally ignored that. I have nothing to disclose. Okay, there we go. There, an incision was made in his chest, circling his left side from breastbone to backbone. His ribs were pried apart, his lungs lifted up, and his ductus was ligated. A second incision was made in his left side to accommodate a chest tube. 3 additional incisions in his neck and chest were needed for the insertion of a Brovia catheter. This procedure proved difficult and had to be repeated. Jeffrey was in surgery a total of 90 minutes. He returned to the nursery in a state of deterioration from which he never fully recovered. He died 5 weeks later. After Jeffrey's death, Mrs. Lawson received his chart and discovered that at no time before, during, or after surgery had her son been given anesthesia or pain relief of any kind. Instead, Jeffrey had been paralyzed with Pavulan, a drug which left him unable to move or react in any way, but fully conscious and able to feel everything that happened during his hour and a half on the operating table. Horrified Jill Lawson raised alarm. Over the following decade, parents, clinicians, and medical ethicists engaged in a heated debate over the question whether premature infants felt pain and whether clinicians should administer anesthesia and pain control. Jeffrey's anesthesiologist explained to Jill Lawson that it had never been demonstrated that premature babies feel pain, and because anesthesia was considered risky for tiny, unstable babies, she had chosen not to anesthetize Jeffrey. Jeffrey's surgeon told Lawson that since the anesthesiologist never told him about her decision not to anesthetize Jeffrey, he did not know he had operated on an unanesthetized baby. The chief of anesthesiology at National told Lawson that the pain of a ductus ligation was comparable to that of intubation, and that Jeffrey's own beta endorphins should have taken care of any momentary discomfort. And a senior neonatologist, also the editor of a major neonatology textbook, told Lawson that her baby was a fetus who could not feel pain, and indeed that babies didn't feel pain until they were 2 years of age. Others, to whom Lawson turned for help, suggested that she seek psychiatric counseling to address what they considered her inappropriate grief responses. Over the following month, Lawson appealed to more than 40 medical organizations and advocacy groups, including various local medical regulatory boards and child protective agencies, the AMA, the anesthesia section of the American Academy of Pediatrics, the American Society of Anesthesiologists, the American Board of Anesthesiology, the Hastings Center, the Kennedy Institute of Ethics, the Baby Doe Unit at the Department of Justice, Child Protective Services, the Children's Defense Fund, the National Perinatal Association. The list goes on. All failed to respond, declined to become involved, or supported the anesthesiologist. Others in the medical community, however, validated Lawson's concerns. Jeffrey's neonatologist, John Scanlon, had regularly referred infants for surgery to National, unaware that the infants did not receive anesthesia. Outraged, he wrote an article about the incident entitled Medical Barbarism, which appeared in Newsday and Perinatal Press. The editor of the journal Birth, too, published an editorial about the case, and both Birth and Perinatal Press printed letters from parents, thus offering the first forum for the discussion of unanesthetized infant surgery and allowing concerned parents and clinicians and ethicists to connect with each other. When in August 1986, the Washington Post published an article on the Lawson case, the mainstream press finally picked up the story. Reprinted around the country, the Washington Post article was followed by 16 additional articles and TV appearances. Parent advocates had begun to reach a national audience. The belief that preemies do not feel pain traces back to the post-World War II period, when surgeons returning from the war turned their attention to the correction of congenital deformities in newborn infants. Because the most common approach of administering anesthesia during this time period was an ether mask in which ether or chloroform were dripped in unmeasured concentrations, many infants suffered cardiac arrest or hypertension and died before the surgery could be performed, leading to concerns that anesthesia itself was somehow bad for infants. In addition, psychology researcher Myrtle McCraw from Columbia University in Babies Hospital had concluded in the early 1940s that infants who had been fed and swaddled did not respond to pain. Putting two and two together, adult physiologists who were given anesthetics during that time concluded that infants did not feel pain. Instead of offering anesthesia, clinicians adopted the Liverpool technique as their standard of care. Invented by Sir Jackson Rees, who was practicing at the Elder Hay Children's Hospital in Liverpool, infants received doses of Curare and were then hyperventilated to reduce cerebral blood flow and thereby provide an anesthetic to those infants. Because the infants were paralyzed as a result of the Curare, some surgeons were unaware that they were operating on an infant who had not been anesthetized. Until the late 1960s, however, most infants did not receive surgeries as a lack of monitoring equipment and instruments suitable for surgery on tiny humans made surgical procedures difficult to perform. Surgeons did not really turn their attention to premature infants until a decade after the establishment of neonatal intensive care units. In 1960, pediatrician Louis Gluck expanded the existing 9-incubator premature nursery at Yale into a newborn special care unit. The following year, neonatologist Mildred Stahlman established a neonatal intensive care unit at Nashville's Vanderbilt University Medical Center. In other medical centers, too, physicians began to experiment with the idea of neonatal intensive care. Hospitals in London, Toronto, Montreal, Stanford, Boston, the University of Pennsylvania, the University of Colorado, the University of California at San Francisco, University of Southern California, and Johns Hopkins University all established NICUs in the early 1960s. With the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling infants as little as possible to one of aggressive treatment. The establishment of clinical centers devoted to the care of premature and sick infants increased the number of infant patients, as well as the clinical problems with which infants presented. It allowed clinicians for the first time to systematically address the surgical needs of infants with congenital anomalies, such as infants born with trisomy 21, with duodenal atresia and intestinal obstruction, or infants born with myelomeningocele, the most common and most severe form of spina bifida, a congenital nervous system defect. Since a third of infants with duodenal atresia have trisomy 21, the classic textbook, The Surgery of Infancy and Childhood, had advised surgeons in the 1950s to carefully evaluate all infants with duodenal atresia and to forego corrective surgery if infants showed signs of trisomy 21. Similarly, before the 1950s, the prognosis for infants with myelomeningocele, which involves varying degrees of leg paralysis and bladder and bowel impairment, was poor. Approximately 80% of children with MMC have hydrocephalus, a serious neurological disorder caused by the abnormal buildup of spinal fluid in the brain, which can result in cognitive impairment and blindness. Most died in the first few months of life of meningitis or as a result of hydrocephalus. Because of the complex medical needs of these infants, as well as the social stigma and isolation of giving birth to a child with a severe disability, children with MMC or trisomy 21 were, until the 1950s, frequently raised in institutions. Indeed, considering the outcomes for these infants extremely poor, clinicians regularly advised parents that infants with trisomy 21 and duodenal atresia, as well as infants with myelomeningocele, be left to die. But in the 1960s and 70s, surgeons increasingly turned their attention to these and other premature infants needing surgical repairs, perfecting their techniques and leading to the establishment of neonatal surgery. For the first time, clinicians were now able to systematically address the surgical needs of these infants, and in the course of the 1960s and 70s, the rise in interventions changed the clinical understanding of what could and should be done for them. In the course of the next 2 decades, advances in therapies and refinement of surgical techniques contributed to the survival and higher functioning of infants with spina bifida and other health problems. By the early 1960s, the development of antibiotics to treat meningitis and of shunts to alleviate hydrocephalus allowed physicians to aggressively treat infants with MMC. And as the 1960s progressed, clinicians' attitudes to infants with trisomy 21 also began to shift. By the early 1960s, the surgical correction of duodenal atresia was well established. Moreover, major changes in the clinical care of premature infants in the 1960s meant that clinicians could now keep their patients alive. The provision of assisted ventilation for continuous respiratory support in the mid-1960s, the development of instruments to measure blood gases and pH levels, revolutionized the field of neonatal medicine, while the introduction of IV feeding and the development of microinfusion pumps allowed for the feeding of extremely preterm infants, and by the end of the decade, high-caloric IV preparations were better able to meet their nutritional needs. As a result, the number of surgeries performed on premature infants rose steadily. Convinced, however, that neonates did not experience pain, neonatology textbooks and medical journals did not discuss infant pain. There were no articles on neonatal pain published in 1977, and only one each was published in 1965, 1974, 1975, and 1976. Two researchers from the University of Iowa pointed to the lack of research and publications on children's pain to emphasize how unprepared nurses were to address children's pain, noting that children were regularly under-medicated because nurses failed to fill orders for analgesics as needed. The authors suggested ways in which nurses might more easily recognize infants' pain and address it. It took until the mid-1980s, however, for clinicians and researchers to turn their attention to systematic research of infant pain. When in 1985 Jo Lawson became aware of her infant son's unanesthetized surgery, she sought out NICU parent turned health advocate Helen Harrison. Harrison had earned a degree in Slavic languages from the University of California at Berkeley and worked as a Russian to English translator and as a medical and laboratory technician with the Berkeley Community Health Project, when she gave birth to her son Edward in 1975. 3 months premature and suffering from listeriosis, a serious bacterial infection, Edward was not expected to survive. When physicians took him off the respirator to allow him to die, however, Edward defied all expectations and continued to breathe. At that point, the NICU staff jumped into action and vigorously supported Edward, who survived with multiple disabilities, including hydrocephalus and severe intellectual disabilities. While Harrison initially had a positive view of the NICU, this changed in the late 1970s and early 1980s when she began to interview parents about their experience with neonatal intensive care units to write a guidebook for parents who experienced the birth of a critically ill premature infant. In 1983, she published the Premature Baby Book and became one of the founders of Parent Care, an international support organization for parents of high-risk infants. I always say that the Premature Baby Book is kind of the equivalent of Our Bodies, Ourselves. It's really the very first work, and it's really kind of the self-help book that Our Bodies, Ourselves was. And I can say that to you because you know what it is. When I say this to my students, they just look at me like, what is she talking about? Together, Harrison and Lawson protested unanesthetized infant surgery in letters to the editor of Birth, thereby laying the groundwork for a media campaign that alerted other parents and exposed the pervasiveness of the practice. 10 years ago, Harrison wrote in her letter to the editor, our prematurely born son, Edward, was shunted for hydrocephalus while paralyzed with Curé. Although he could not move, cry, or react in any way, he could see, hear, and feel as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain, then pushed down under the skin of his neck, chest, and abdomen, and implanted deep in his abdominal cavity. As the story made it from the Washington Post to papers around the country, parents realized with horror that their infants, too, had not received anesthesia or pain control during major surgical procedures. In Oakland, California, Jacob Eli Schrag, born at 23 weeks gestation, had had abdominal surgery at Children's Hospital on the 17th day of his life after he developed necrotizing enterocolitis. Jacob's parents had been told during the pre-op consultation that Jacob would receive medication to relieve his pain. But after requesting Jacob's medical records, they discovered that he had only received a muscle relaxant. He died the day after his surgery. Horrified, Jacob's parents described the surgery without anesthesia as appalling and barbaric. In Florida, Carmen Mercado, born in 1983 at 28 weeks gestation, had 4 brain surgeries without anesthesia. When her mother, Linda Mercado, refused consent for her daughter's surgery after she learned the surgery would be performed without anesthesia, she was reported to Child Protective Services as an abusive parent. And in Ohio, Barb Dasher's premature son, Keith, had heart surgery without anesthesia. Journalists reporting on these cases illustrated the prevalence of the practice, and NICU parents reading about these cases began to investigate whether or not their premature infants had received anesthesia. Parents did not just object to their infants' experience of unanesthetized surgery. Throughout the 1980s and 1990s, they discussed a wide array of painful medical procedures their children had been subjected to: major surgery, chest tube insertions, all performed without painkillers, gangrene and amputation from infiltrated IVs, bones broken during chest physiotherapy, skin pulled off with adhesive tape, and burns from the monitors. Added to that were the 24-hour-a-day bombardment with bright lights and loud noise, and numerous iatrogenic afflictions from improperly evaluated therapies. If this were going on in any other setting, one mother exclaimed, it would be called torture. I'm sorry about that. That's my phone. It's a loon call, just ignore it. Means that when I'm in Maine, I don't know whether my phone is ringing or whether there's a real loon. Contrary to the medical literature and clinicians' widespread belief, parents also insisted that their children did remember pain inflicted in the NICU. I have long wondered how an infant can differentiate between pain or abuse that is medically necessary and abuse at the hands of an out-of-control parent or caretaker, one parent noted. It is generally acknowledged that abused infants become emotionally scarred. No one says they will be fine because they can't remember, yet the myth remains that the NICU veterans forget. Parents argued, moreover, that the pain experience led to deep and long-lasting trauma. We have seen our child grow obsessed with medical pain, Alfred Harrison told an audience of parents and neonatologists in the mid-1990s. The thousands of other painful procedures inflicted on Edward, both in the nursery and later, during shunt revisions, heel cord surgery, and other operations, have left an obsession with pain in this retarded child's mind. We can't even take him to the pediatrician for a routine checkup without him literally shaking in fear with sweat popping out on his forehead. It's not that the pain comes and goes and it's forgotten. It's always in his mind. For many NICU graduates, the NICU was only the beginning of years of medical treatments they had to endure. Infants who had received shunts for hydrocephalus, for instance, could face many surgeries for shunt revisions as they outgrew their shunts or as the shunts became infected. By the mid-1990s, 16 years of age, Edward had endured 13 surgeries, including 7 in the past 2 years. Many children experienced these procedures as painful and traumatic. As one mother reported about her 8-year-old son with whom she tried to talk about his shunts, he keeps saying that it's too scary. He doesn't want to hear about it. And every time she took him to the doctor, he, like Edward Harrison, shook and trembled, and it took him days to get over it. Parents were also outraged at their lack of legal redress. While they ran the risk of being reported as abusive parents if they refused consent for their infant's surgery without anesthesia, the child abuse laws only applied to parents. Since withholding anesthesia from infants fell within the standard of practice, and since physicians were presumed to be acting in the child's best interest, their withholding of anesthesia and analgesics was not considered child abuse. Over the following months, Helen Harrison and bioethicist Nance Cunningham Buckler interviewed clinicians around the country to determine how frequently clinicians ignored infant pain. They found beliefs about infant pain to be varied and contradictory. While some physicians noted that their years of experience convinced them that babies felt pain just as acutely as adults, others claimed that their years of bedside experience convinced them that babies did not feel much pain. Still others claimed that it was irrelevant whether or not babies felt pain, since they couldn't remember the experience. Yet others pointed to evidence in the literature that neonatal pain could have lasting, detrimental psychological effects, and claimed that not offering pain control was unethical. For those who acknowledged that babies felt pain, what they chose to do about it varied as well. Some maintained that it was unethical to give pain relief until well-controlled studies with long-term follow-up demonstrated the safety of pain medication and anesthesia. Others, by contrast, pointed out that virtually nothing done to babies in the NICU had been subjected to such studies, and that neonatologists on a daily basis used agents with far more serious side effects for far less obvious reasons than the relief of severe pain. Harrison, Lawson, and Butler noted in particular the double standard toward humanitarian considerations in favor of pain control. Pain relievers were also risky for adult patients, they pointed out, yet when physicians made risk-benefit calculations for verbal patients, humanitarian considerations in favor of pain control were given considerably more weight. But those who began to challenge the lack of anesthesia and pain control in the 1980s were regularly met with hostility by their fellow clinicians. When in the early 1980s, Kanwaljit Sunny Anand began to research stress responses of neonates to the lack of pain control, he met opposition and resistance all the way. As a young Rhodes Scholar at the University of Oxford and house officer in the special care baby unit, Anand had observed the stress reactions of premature babies to needle sticks when he took their blood. In addition, severely ill infants in his care returned from the operating room in significant distress, with unstable blood pressure and heart rates, some developing brain bleeds. But his efforts to draw attention to neonate pain responses was hobbled not only by the deep-seated beliefs that infants did not feel pain, but also by Anand's identity as a young Sikh doctor from India. As he recalled, being Indian in the UK in 1982, only 35 years after the end of British rule, we were considered second-class citizens. Barely 24 years old, no one took me seriously. They said, no, the belief that infants don't feel pain is standard knowledge. It's in the textbooks. When his mentor asked him to study the impact anesthesia for women undergoing cesarean sections had on their infants, Anand suggested that he study the effect of anesthesia given to the baby instead. His mentor dismissed Anand's concern. He said, ridiculous, there is no role for anesthesia in a baby. But Anand persevered and in an initial randomized controlled trial of 30 infants was able to demonstrate that infants showed a surgical stress response 3 to 5 times stronger than that of adults undergoing similar surgery. Resistance to his belief in neonate pain hobbled his ongoing research efforts, however. For another randomized trial, Anand traveled to Harefield Hospital, northwest of London, where Sir Magdi Yaqub, a prominent cardiothoracic surgeon, performed surgeries to correct congenital heart disease anomalies in newborns. As Anand recalled, I would ask them to pick an envelope. And opening the envelope, they would get this postcard saying, this is the anesthetic technique that you will follow. And so there was enormous resistance. I was literally opposed in the operating room saying that I've been practicing anesthesia for 40 years. This is the way I've done all newborn surgeries. You think I'm going to follow this postcard? And what kind of qualification do you have to dictate? And all I would say to them is that this has been approved by the Hospital Ethics Committee. This child is already enrolled. The parents have given consent, so I am afraid you will have to follow the protocol. And to say that in the most humble, obsequious way. Slowly, gradually, people just barely tolerated me. In 1985, Anand moved from Oxford to a postdoctoral fellowship at Harvard University. 2 years later, he and his colleague Paul R. Hickey published the first scientific explanation of neonatal pain, tracing the anatomy of pain and behavioral changes in neonates in the New England Journal of Medicine. Anand's survey of the literature discussed that mentions of pain or guidelines for pain relief had been conspicuously absent from pediatric and neonatal texts, and that 80% of ductus operations, for instance, had been performed with little to no anesthesia. Other clinicians, too, found that unanesthetized surgery for infants up to 15 months of age was the rule rather than the exception. When the AAP surveyed hospitals about the practice in 1987, they found unanesthetized infant surgery was not uncommon. An anesthesiologist familiar with the survey characterized the findings as appalling. You cannot imagine how much I'm longing to go into the AAP archive and look for that paper. That fall, the AAP issued a statement recommending the use of analgesia and anesthesia for neonates. And while the American Society of Anesthesiologists voted at their October 1987 meeting not to endorse the AAP statement on neonatal anesthesia, by December, the ASA gave the statement their stamp of approval as well. Until the mid-1980s, almost non-existent, randomized controlled trials surrounding neonatal pain responses steadily increased after 1985. Despite the support from the two professional societies, however, clinical practice was slow to change. Instead, while one group of clinicians now devoted their research to the development of criteria indicating neonatal pain and of medication protocols to provide clinicians with guidance regarding the administration of analgesia and anesthesia to small infants, Others continue to deny that infant felt pain, that the administration of pain relief was appropriate, even if clinicians did not understand the experience and memory of pain in neonates, and that administering pain relief to neonates was safe. As a new subspecialty, whose primary goal it was to save the lives of premature infants, pain inflicted in the process of performing medical procedures was not a priority to clinicians. Of all the issues I deal with, one neonatology intern noted, whether or not I'm hurting a child is probably the least worry because I don't do anything I don't think is necessary for their survival. Saving life justified extreme measures, including the infliction of pain. A number of observers noted that clinicians' focus on measuring respiratory, cardiac, digestive, and temperature functions in neonates meant that many neonatologists thought of their patients as machines that put out measurable data. Nonverbal pain responses were considered unreliable indicators, soft data that could be interpreted in many ways and was therefore usually ignored or dismissed. When Anand and Kenneth D. Craig suggested in 1996 editorial in the journal Pain that the definition of pain should be amended to include nonverbal behaviors to allow consideration for those incapable of self-reporting pain, newborn or older infants, small children, mentally retarded, comatose, demented, or verbally handicapped individuals, those critical of the existence of infant pain engaged in debates over semantics rather than focusing on the experience of neonates undergoing painful treatments. Opponents vehemently resisted a redefinition of pain. It was impossible to include pain behaviors in the definition of pain, psychiatrist Harold Mirsky, chairman of the Taxonomy Committee of the International Society for the Study of Pain, claimed. Certain types of behavior may be defined as probable pain indicators, he argued, albeit the baby should be both wincing and crying to qualify. We cannot assume that those responses would always be true pain indicators because there will be times when we do not know whether they indicate wind or anger rather than pain. We might talk of apparent probable pain or even apparent very probable pain. It is a misdirection of energy to attempt to change the meaning of a word that, so far as I can tell, has been used everywhere, or perhaps almost everywhere, in a particular way for thousands of years. And Stuart W.D. Derbyshire, a psychology research fellow at the University of Manchester, also pointed to the weight of history to argue against redefining pain. The pain experience, he argued, was a multidimensional phenomenon, contingent upon general conscious awareness, including evaluative, emotional, and cognitive processing. But since the neonate was naive as to all cognitive, affective, and evaluative experiences necessary for pain awareness, it did not feel pain. Anand's and Craig's proposed redefinition, Derbyshire complained, constituted a complete destruction of the understanding of pain developed since 1965. The diversion into a debate about semantics served to uphold the existing clinical system rather than open clinical care up to debate and reform. It also illustrates the refusal to acknowledge the humanity of the neonate. As Elaine Scarry noted in her 1985 study on the body in pain about those in authority to inflict pain, he first inflicts pain, then objectifies pain, then denies the pain, and only this final act of self-blinding permits the shift back to the first step, the inflicting of still more pain, for to allow the reality of the other suffering to enter his own consciousness would immediately compel him to stop the torture. Disciplinary boundaries between pediatrics, neonatology, anesthesia, and psychiatry, psychology lend the debate a particular intransigence, as clinicians from one discipline were resentful that clinicians from another discipline questioned their ethics. Values about protecting the self, colleagues, and the integrity of one's professional training prevented clinicians from acknowledging the existence of infant pain at administration of pain control. Finally, resentment toward parents who had embarrassed clinicians with their public protest and media campaign contributed to a standoff between those advocating for change and those resisting it. In the end, the relentless protest of parents and support from clinicians who did offer analgesics and anesthesia to neonates led to changes in clinical practice. By the late 1980s, clinicians repeatedly demonstrated that infants and children did indeed experience pain and that the administration of anesthetics significantly reduced infant stress during surgical procedures. And an increasing number of articles offered guidelines for pediatric pain management, including details about dosages for neonates. Still, NICUs varied widely in their use of pain medication for neonates. While Linda Sterler Frank found in the late 1980s that nurses offered an impressive list of drugs, 21, used to address neonatal pain, only half of those drugs had actual analgesic effects. Neonates, Frank concluded, were not routinely pre-medicated prior to invasive procedures, and infants who were paralyzed did not routinely receive medication for pain or sedation, even though these infants were often the most critically ill patients in the NICU and underwent many painful procedures. Finding that nurses regularly failed to administer pain control as much as they should, others suggested that training programs should better prepare nurses to assess and alleviate children's pain. By the 1990s, attitudes about neonatal pain had begun to change. As a survey of 352 physicians certified in neonatal perinatal medicine illustrated, almost all respondents agreed that even the most premature infants could perceive pain and advocated for the use of anesthesia for both minor and major surgery. Among other factors, the widespread coverage of the issue in the lay press and pressure from parents and nursing staff had contributed to changes in physicians' attitudes and practices. Nevertheless, older physicians were more likely to hold on to beliefs that neonates felt less pain and required less pain management than adults. Unrelieved Pain, a 1994 editorial in the New England Journal of Medicine, cautioned not only caused higher stress responses in premature infants, but could endure in memory, resulting in disturbances with potential long-term implications affecting future experiences of pain. The assessment and treatment of pain in children are important parts of pediatric practice, and failure to provide adequate control of pain amounts to substandard and unethical medical practice, the authors concluded. Indeed, in recent years, survivors of unanesthetized infant surgery have talked publicly about the trauma the experience has caused them and their families of origin. Survivors have described the impact the lack of anesthesia and pain control has had on them, including rage, anxiety, depression, low self-esteem, self-harm, suicide attempts, and general PTSD. Unaware of the cause of their lack of well-being, many survivors took decades to connect their physical and psychological difficulties to the lack of pain control as infants. Parents, too, were traumatized by their severely ill newborns and their inability to protect their newborns from painful medical procedures. At times, they unwittingly aggravated their children's negative responses by regularly telling stories of their infant's severe illness and near death. As survivors have written memoirs, blog posts, and produced a documentary about unanesthetized infant surgery, they have been able to locate each other, understand their own experience, and offer each other support. Neonatal technology has made great strides since the 1970s. Its progress, however, rests on a legacy of infant and parental suffering. Today's apparent successes and safety has too often been achieved through mistakes, as every triumph in neonatal medicine sits atop earlier tragedies. The urgency of saving the lives of premature infants frequently overshadowed clinicians' ability to acknowledge and address infant suffering. And in a context in which the best interest of the infant was always assumed to mean that clinicians should fight for the lives of neonates rather than consider comfort care, taking the burdens of treatment and infant suffering into account didn't seem like a legitimate choice. The result, however, were distressed parents, as well as clinicians who suffered from moral distress. This was brought home to me the very first time I presented work about unanesthetized surgeries, and after my talk was suddenly faced with clinicians who, in tears, told of their memories of work in the NICU. Clinicians must pay close attention to the potential suffering of infants and be willing to acknowledge and address it. In addition, they must be deliberate in considering what it feels like for nurses at the bedside, as well as for themselves and their colleagues. As the recognition and acknowledgement of suffering must be followed and the recognition and acknowledgement of suffering must be followed by a potential reconsideration of treatment modalities. Finally, today's political context echoes the baby doe era, in which pro-life legislators exploited fetal rescue to limit women's access to reproductive technologies while cutting existing disability services. As we embark on the next developments in neonatology, I was just at a symposium on the artificial womb. We need to be aware that we're trying to rescue fragile infants in a context in which the federal government is systematically canceling healthcare and support services for the most medically vulnerable members of our society. Oh, those are the takeaways. But really, I want to go there. Thank you so much. And we have time for questions.
We do. Thank you for teaching us. That history is so compelling, and really also a history of how we change our minds about things and what has to be overcome, and to go through to change our minds and be flexible about it. What have you learned about sort of how people change their minds? It seems like some of the doctors were immediately horrified, change their mind right away, and other ones were just so white-knuckled grip on what we've been doing for a long time.
Yeah, I don't know that I have really learned anything about the process of clinicians changing their minds, short of the fact that it's become very apparent how difficult it is, right? And particularly for those disciplinary boundaries, and also particularly because if you have been taught and if the entire literature states one thing and then you're supposed to kind of acquire something new, it's not only a reconsideration of your own knowledge, but also of the values and the values of your teachers and the values of your colleagues. And I think one of the problems, particularly with the pain control in NICUs and towards children in hospital in general, is that my sense is that it's really unit specific. So it's not necessarily that one clinician in one unit is going to do one thing and another clinician in the same unit is going to do something else. It tends to be by unit, which also means that often when I present this, not often, but sometimes when I present this talk and I have older neonatologists in the audience, the response will be that they come up to me and say, but I didn't do this. And so, yes, that's possible because 80% of, I'm at the moment operating on the 80%. So the AAP actually did a survey of clinical services to see the percentage of places that didn't provide anesthesia and analgesics. But I haven't found anything except for the characterization of the results. So I am really hoping to find more specifics in terms of numbers. At the moment, I think partly because Anand said that his research indicated that 80% of doctors' ligations were done without pain. I have pain control. I've kind of translated that into other surgeries. So, I think there are also a lot of institutional barriers that make it difficult to really change practice.
Wait, you can just call them.
Don't need a microphone.
Oh, no, go ahead.
So on your map of all the NICUs, I was at the UCSF NICU from 1972 to 1975. I'm not a neonatologist. I thought about being one, but didn't go to neonatology, but I was attracted to it.
Yeah.
I remember, I can even come up to, as you were talking, I can remember babies going to surgery when I was a first and second year resident, a particular heart lesion that they actually had. I don't remember any discussion whatsoever about anesthesia or lack of anesthesia. Do you know what I mean? It
Yeah.
was like in academic discussions, we always had rounds on Fridays, the arguments about what was in the literature. I just don't remember the discussion.
Yeah.
I do know that was around the time, like the early 70s, where the patent ductus started to get ligated.
Yeah.
They went to the operating room. They weren't in the NICU like I know they are
Yeah.
recent years. But I just don't remember. I wish I did. The one thing I do remember in the by the late 70s, when I was a genetics fellow, and the discussions about not operating on children with Down syndrome, with neonatology was a conversation.
Yeah,
We had, I do remember morphine being used at that time.
yeah,
Meaning, not that I knew morphine was used in a baby, only morphine was given to babies at the time.
yeah.
But my wife was a NICU nurse, we met there, and so later this morning, I'm gonna ask her, I'm gonna ask her her memory of sedating babies, and since I'll see you later on today, I'll let you know what she tells me.
Yeah, I would be super curious. I might also want to interview her.
Well, she was there from 1972 till we left San Francisco in 79 and came here.
Okay,
So she did have 7 years of San Francisco neonatal experience as a,
and then did she continue in the neonatal intensive care
she
unit?
went to become a nurse midwife when she got here, so. Anyway, but she wrote her master's thesis on here.
Yeah.
In interviewing families in the NICU here. Even though she became a nurse midwife, that was actually her master's.
Oh, I really do want to talk to her, actually. Now I want her master's thesis.
The library, I think, got rid of all of them, but we still have them.
I was hoping.
Red I'm sure that my wife Leslie would be happy to, just, she knows about your talks. I'm sure she'd be happy to talk to you.
Thank you so much.
So this feels very parallel to the recent conversations around OB anesthesia. And
Yeah,
I think it's
Yeah.
interesting to me as a pediatrician and a woman, how we don't consider the fact that we're human.
Yeah.
And instead we disregard, like men are special and can feel pain and therefore we treat their pain
yeah,
and ensure that they're not experiencing surgeries without anesthesia. But women, that's because it's dangerous.
yeah.
And babies, they can't remember it. It's not surprising, but it's interesting.
It's interesting that you say that. So my wife is a therapist, and so she looks at the human experience in slightly different ways than I do. And she mentioned to me at some point that she wasn't convinced by the story because given the number of neonatologists and clinicians who were male and who did not experience pain as early as women do when they have children, right? They might go through a number of decades of their life without that particular experience. She also felt like because they don't have any personal experience, that what you're saying, right, that level of understanding and empathy just wasn't readily available.
It's fascinating, Dr. Schoen. Thank you for sharing. I wanted to make a connection between this and the earlier work that you've done on, on the history of abortion.
Yeah.
I was curious, over this period, because it's only a sort of decade or so after Roe, did you notice any explicit or implicit sort of reflections on how the conversation in neonatology might have implications for how people are thinking about the broader conversations of abortion? Because I would think if you open the door and grant that premature babies, that neonates, that fetuses feel pain, it now, and you're also pro-choice, you might worry that this is sort of providing an argument against this other thing that you're simultaneously trying to advocate for.
Oh, it lands right in the middle of that
Yeah.
debate, right? So the time period at which at which Anand comes about and does his research and this debate starts, is also the time period where pro-life advocates are trying to argue against abortion because it is painful to the fetus. And the responses when I was writing the book on abortion after Roe, I went to the meetings of the National Abortion Federations every year. So the responses of abortion providers to that question is multifaceted. But it is, I think neonatologists are surprised because they don't think along those lines, but Anand and his colleagues at Oxford, for instance, his supervisor get caught in the debate and get accused of pro-life advocates in England of performing medical experience, performing medical procedures on infants without pain relief, they also totally misunderstand what it is they're doing, and they're trying to make it a scandal. And then after they understand what really happens, they do send an apology. But then he comes to the US and the debate is the same, right? So I think neonatologists don't expect to land in that debate and are surprised when they do. Mostly, I think they don't really say anything about the abortion aspect. They wisely keep out of it. Yes.
Thank you. I'm curious about when you're interviewing the parents and the survivors of this trauma, what is your approach for interviewing them in a way that doesn't inadvertently re-traumatize them through asking them to share these difficult stories?
I have actually only interviewed one parent, and I interviewed the parent because she is a social worker at a NICU. But I have sent what I wrote both to Alfred Harrison, and if you're coming to the Ethics Explained or whatever it is, there is a case that was in the reading that I sent of Susan and John West, and I met Susan and John West and talked about their experience, not in a formal interview, but over a coffee at some point. And they both said that reading the work re-traumatized them, but I think they were also really grateful that somebody is writing about this. So, you know, I think as a medical historian, also with the work I've done earlier, sometimes that is just part of the course in a way, that you write things that are hard, that are morally distressing, that might be re-traumatizing somebody. That does not mean that we shouldn't investigate it, however. So I try to be mindful, and I realize that that can happen, but I don't have a particular approach to it. I don't tend to interview parents. Parents have written enough that I don't need to rely on interviews. And for me, a little bit, I don't know how to explain it, but the ethical quagmire that I can get into if I would interview parents is a little bit too complicated for me. So I haven't gone there yet, and I don't know that I will. I do clinicians, and there are enough clinicians who have a variety of viewpoints that, you know, I feel like I'm covering my bases that way. And then with what is in the Helen Harrison papers, and parents have written so many memoirs about having NICU babies and raising them and the likes.
Noon Ethics Explored, we're discussing moral distress in the NICU, and that should be in your program if you want to come to that as well.
Are there any online questions?
There aren't questions, but there are some comments. So it's from also older doctors, like in the chat here. This is agonizing and shameful to hear how we as advocates for children could not imagine infants suffering pain. This was all during the careers of some of us older in the audience. Circumcisions need pain met, somebody said. And our emotional protective behavior to be right covers our self-doubts, and that can prevail in us as we deal with huge amount of information in the life and death settings.
Yeah, I think that kind of gets back to your question, right?
Yeah, thanks, Dr. Kramer, for the comments as well.
Any provider who still says we were doing the right thing or this was the best thing, have you run into anyone who's still?
The number of clinicians I interviewed is, compared to that, not that high. I think I'm at 10 or 15 or something like that. I also doubt that any clinician would admit that they were part of a group of people who really believed that infants did not feel pain. I think, yeah, I can't really imagine that they would, so. Yes?
And also just to point that this is kind of a double-way street, given the DSM-5 definition of ethical and moral trauma. So it also goes towards the providers.
Yeah.
So how does it affect them?
Yeah, I mean, it affects them greatly, right? I don't know whether it affects all providers, but it certainly affects many providers who are traumatized by that, including the ones that came up after I presented this the first time in tears. And it was interesting to me in the sense that I did not expect that response at all. Now I kind of know to expect it. I think that's the other reason that I'm really interested in the question of moral distress and how do you do your work when you're in a context where the choices that you're making are often dictated by other things than what you feel is the correct way of doing stuff. So I think it's really complicated.
That noon session will be very good. Well, thank you again for teaching us today, but we're so grateful. The claim credit code is 52522. And, this Grand Rounds have been going over 50 years, trying to get different perspectives from different units and across the country and world coming here, and we go and share in other places. And hopefully we end up learning from each other along the way. And we're thankful that you came with your perspective as well. Thanks.
Thank you so much.